In relation to the epidemiological study, I have reviewed two examples, one an American study and second a UK one from the University of Sheffield. I have attempted to draw similarities and differences between the two Western locations. First, I've reviewed the study entitled The Epidemiology of Homeless Population and the Impact on the Urban Emergency Departments. This American study incorporated 252 homeless people who took part in a 50-question questionnaire. A remaining 8,000 people, also deemed to be homeless, but were deemed to be psychiatrically ill and therefore excluded from the study. The conclusions of the study highlighted the following: significantly higher rates of infectious diseases, ethanol and substance misuse, psychiatric illness, social isolation, high rates of emergency department utilization. The American study talked about homelessness as a social disease of epidemic proportions. The average life expectancy in America for a man was 44 years, with homeless people amassing some 20 to 30% intake of all adult hospital admissions. The cost of this homeless intake was stated at being $2,000 to $4,000 per day per admission. The actual questionnaire was conducted in English and Spanish, which was reflective of the ethnicity of the homeless people surveyed. Both physical and mental qualities, history, were assessed in the questionnaire. There were four main social aspects which were determined across the study. Number one, homeless people were subject to high levels of social isolation. Number two, a high proportion had been subject to assault. Number three, a high proportion were requiring public assistance. And number four, there was a very low employment rate in this group in particular. One of the infrastructure findings was that providing compassionate, goal-directed care directly reduced admissions. However, it was noted that most accident and emergency departments do not have social workers or staff to this expertise, so this would require an infrastructure change and if it were to attain a long-term impact for this group. It's also noted that very few female patients were represented within this study. The second study, commissioned by the University of Sheffield, found that between the years 2001 to 2009, 1,731 deaths had occurred, which were classed as homeless people deaths. 90% were male and 10% were female, from a population size of 4,573,667. Nearly a third of these were from the London region. The average death age in a homeless person in the UK was 47 for men and 43 for women, compared to 77 for the general population. Drugs and alcohol abuse are particularly common causes of death amongst the homeless population. The message from the study is that ultimately homelessness kills. The Sheffield study source was an investigation of mortality rates of homeless people in England from the period of 2001 to 2009, and also research conducted by Crisis. Despite the best efforts of homeless organisations and government initiatives, homelessness is very much a modern societal problem with devastating consequences for the individuals and families. The reasons cited for this ongoing reality included economic downturn, coalition cuts to welfare, particularly housing benefit. Homelessness is on the rise again. Looking at the American epidemiology study versus the UK one, there were striking similarities as to the symptoms of health presentations, e.g. drug and alcohol abuse, diseases, respiratory problems, mental health issues, etc. What was different was the language that was used. The American study used the words homelessness is a social disease of epic proportion. This really struck me as a negative approach and symbolic of the stigma and blame culture which transpires in society when we think about homeless people and their circumstances. These people are marginalised and isolated and vulnerable, and sometimes not in the best place to conform to society's expectations or concepts of self-efficacy. Both studies outline facts, but the exclusion of 8,000 people on the grounds of mental capacity, are we actually getting the proportionate picture of what it truly means to be homeless? And how big a national issue is homelessness? There is very little in respect of current studies which suggest homelessness is not on the political agenda of priorities. Other social factors like refugee camps emerging in Europe, and also what proportion of today's homelessness are refugees themselves, and what is being done to help and create a moral cushion or compassion and assurance that these issues are being looked at as well as the perceived problems being supported to conclusion. The shocking truth of the two tables from the UK study shows that where you reside geographically has a bearing as to how a homeless person will die in respect of cause of death, with drugs and alcohol abuse taking centre stage of root causes. Unhealthy lifestyles and behaviours are the main factors which arise from the above reports, but they almost create a blame culture. These homeless people are victims of troubled past and circumstances. They are not to blame, but their capacity, knowledge and desire all determine their future prospects. With infrastructure and support, the outlook at the moment is grim, which the pie chart and the tables show. How do studies such as the two presented here contribute to making a difference? These reports are standalone, removed from but reflective of the reality a homeless person lives and dies from. These studies highlight areas of concern in society, culturally, socially, psychologically and mentally, highlighting a platform of information to influence and steer both national and local policy.